Welcome to this video on neonatal endotracheal intubation, based on the textbook of Neonatal Resuscitation, 9th edition. Our focus is to secure the airway and save the brain. By Dr. Salem Keshba, neonatal specialist. Key anatomical differences in the neonatal airway include a high and anterior larynx, a larger omega-shaped epiglottis, a large tongue, and angled vocal cords, all making intubation challenging. Remember the clinical pearl. Sniffing position is critical, avoiding hyperextension. Indications for intubation include ineffective positive pressure ventilation, mandatory placement for chest compressions, surfactant delivery, congenital diaphragmatic hernia, airway obstruction from meconium, and various facial or airway anomalies. A preparation checklist for equipment is essential. Endotracheal tube and blade sizes vary by weight and age. For example, infants under 800 grams require a 2.5 mm ETT and a 00 or 0 blade. A tip is to have one size smaller and one size larger ETT than your estimate available. Except in emergencies, elective intubation uses a standard sequence with pre-medication to minimize pain and instability. Fentanyl provides sedation and analgesia. Succinylmethonium is a muscle relaxant with a fast onset, requiring ventilation backup. Atropine can be used to prevent reflex bradycardia. The intubation sequence involves 4 steps. Align the infant in the sniffing position with a shoulder roll. Entry involves sweeping the blade to the left. Identify the vocal cords by advancing the blade. Insertion is the passing of the ETT between the cords, avoiding pushing too deep. Limit attempts to 30 seconds. The 9th edition updates the depth of insertion to the tip-to-gum measurement point. The new standard for oral intubation is weight in kilograms plus 6 centimeters. This is the equivalent of the traditional, quote, 7-8-9 rule. Other methods are the nasal tragus length plus 1 centimeter and gestational age charts for ELBW infants. The gold standard for placement verification is CO2 detection, indicated by a color change from purple to yellow. Other signs include a rapid rise in heart rate, bilateral breath sounds, mist in the tube, and symmetric chest rise. A warning: CO2 detectors may not change color with low cardiac output. Video laryngoscopy is increasingly used by experts for shared team view, superior training opportunities, and improved first attempt success rates. Remember, do not rely solely on the screen. Always maintain your direct laryngoscopy skills as a backup. When managing a failed airway and sudden deterioration after intubation, use the DUPE mnemonic: displaced, obstructed, pneumothorax, or equipment failure. The failed attempt algorithm suggests resuming mask PPV, calling for senior support, trying video laryngoscopy, then laryngeal mask, and finally, surgical airway if necessary. Effective team dynamics and communication, known as crisis resource management, are vital. This includes using closed-loop communication for confirmation, thinking out loud to share your mental model, and designating a timekeeper. Always perform an airway timeout before entry to confirm details and roles. In summary, remember to intubate before chest compressions. Placement confirmation relies on yellow equals trachea, and purple usually equals esophagus. The new depth rule is tip to gum equals weight plus 6. Thank you for your commitment to neonatal excellence. These are the image sources for this video.